Dear chairmen, dear colleagues, and first of all, I want to say thanks a lot to Sergey, who invited me for this meeting. And it's a big honor for me to be here at the third BRICS Spine meeting. And I want to, in our talk, I want to share our experience in the hard way of treatment of patients with a metastatic spine. How you can see, our experience is the more than 2,000 patients, for more than 2,000 surgeries for the patient with a tumor spine, which with a follow-up for 15 years. And you can see that the surgical activity for this category of people is dramatically increasing year by year. And now we have, I would say that it's 25–30% of all spine cases in our center. So you can see that metastatic spine takes more than 60% of all tumor cases. I would say that the surgery is the last chance to help these patients. It's not the preventive medicine for them. Today we have a lot of opportunity to treat these patients with the chemotherapy, radiotherapy, and you can see here the examples. The patients from the left side is the patient with the multiple myeloma, with the spinal cord compression and the neurological complications, and after some chemotherapy with the total restoration of the shape of the vertebral channel and total recovery of the patient. The next one is the two cases is the patient with the breast cancer. That's why I would say that in the last 10 years, the quantity of the patients with the primary tumor site is dramatically changed in our operation field. I would say that maybe 10 years ago, the patients with the breast cancer and multiple myeloma, prostate cancer was the best candidate for surgery. And now you can see that they are disappeared from our operation theaters because the effectiveness of the chemotherapy, hormone therapy, and radiotherapy is very high for them. And almost maybe 15% need the surgery still now. But another way, for result of the good chemotherapy and extension of the life of the patients, we can see that the patient with the kidney, renal cell carcinoma metastasis, lung metastasis, gastrointestinal metastasis, I mean, even liver metastasis. I mean, these patients, which maybe 10 years ago, we couldn't even expect to do the surgery for them because they are not, it was not candidate with a good prognosis for the life expectancy. That's why they are coming now. They are coming to our operation, and we have to do with them something to improve the quality of life for them. That's why the decision-making process for this category of patients, it's a very hard way. It looks a little bit simple, just 3 main steps: histological verification of the tumor, then evaluation of the staging of the tumors, a staging of the oncological process, and then the third one, and the very important, it's the oncologist consult. It's the multidisciplinary approach. It's the decision about the surgery and about the treatment strategy for these patients. It's the part of the oncologist, chemotherapy, radiologist, pathologist, and surgeons. That's why only group of the people individually can do the strategy for these patients. So you can ask me about the prognosis, because in the beginning of our way, a lot of people ask about what the prognosis of this patient, what the life expectancy for them, and what reason to do the surgery for them. And we studied a lot of scales which we have for today, and I would say no one is work. We don't have prediction factors which can be we can orientate using them for the prognosis of the tumor process. And then that's why you can see just a few factors. It's primary tumor site, performance status, SAA classification, age, gender, number of metastasis, location, and pathological fracture. Only these prognostic factors are very strong, and we can use to decide about the surgical strategy for them. But anyway, today we have only one factor to do the surgery for these patients. The main, you can see, that's operability of these patients. If they can be operated, we can do this surgery. So, what is surgical strategy? It's the multi-stage. It's the minimal as short as minimal. You can use the percutaneous techniques if you can do and can help this patient with the percutaneous vertebroplasty. It's a great deal. But if you're not, you can do the surgery. Percutaneous, minimal invasive. Your approach to this tumor must be straight. Don't please avoid 360 degrees surgery for this category of patient. It should be target surgery. And here you can see an example, for example, this man with the lung cancer with a not so good prognosis of the life, and the idea to relieve the pain and stabilize the spine. You can see this is the approach and the surgery with a few days of the post-op in the clinic, with a good satisfaction of the patients. Multi-stage surgery, because the people are living longer. I mean, our patients, the patients with the multiple myeloma, you can see here, the patients with the breast metastasis, even with the renal cell carcinoma metastasis patients could be operated several times after the evaluation of their metastatic process for several years after that diagnosis. And here you can see the patients which in 2002 verified the multiple myeloma, and with the progression of the disease in 2020 with the multi-level decompression and stabilization. Then there was the pain syndrome and problem in both hips. We did this stabilization of the hips. Then that was the prognosis 3 years ago. After that, it was the progression with the local progression of the disease in L2 level with the stenosis and neurological deficits for the patients. And we did the anterior approach and this. And so you can see in 15 years out of her life, we did the surgery, because all this surgery helps to improve life condition. Можно обратно? Sorry, я пролистнул, как обратно. So another problem, it's the revision surgery for metastatic patients. Maybe 10 years ago we cannot expect about that, but now they are living longer till again, and we have to do the revision for these patients. We increase the surgical aggression in this case, and according to my first talk in this Congress, I would say we have to plan in before the surgical, to decide the surgical strategy, which type of technology we have to use to reduce the risk of the instability of implant and fracture of the hard way. Combination of the treatment, the radiation therapy. Here you can see the example of the renal cell carcinoma, minimal invasive approach. It's the new way which called separation surgery. So we retrospectively studied a group of the 40 patients with the renal cell carcinoma. We divided in two groups in which we did the, in case of the solitary metastasis of renal cell carcinoma, we did the metastasectomy. In other group, we did the palliative decompression, the separation surgery with the stereotactic radiation therapy first month after the surgery. And you can see that the result was the same. I mean, that's the disease-free survival and overall survival for this patient was this similar results. That means it's not necessary to do the very aggressive surgery today anymore, because we can use the cooperation with our rentgenologist and achieve the similar results. Another point in the treatment way of these patients is what to do in the acute situation when you have severe spinal cord compression with a neurological deficit and not verified histology, verified tumor, because it takes time. For example, this case, the young lady with a stenosis of the spinal cord, tetraparesis, and asphyxia also. And we don't have the time for biopsy and waiting several days or weeks for histology verification. But that was the only one tumor mass, and we decided for young patient with a good somatic status, and we did the aggressive surgery for this, radical resection, and she was pretty lucky because it was the giant cell tumor. And anyway, the second stage in this situation, we recommended to do the MIS surgery. Decompression is like a open biopsy with sometimes with the short fixation, percutaneous fixation, and then we, in few days or weeks, we have the histological verification of the tumor, and then to decide what to do with this patient in a post-op. So, and also don't forget that the cause of pain for this patient could be not only the tumor. Here you can see the patient with the breast cancer, the metastasis, and the degenerative spine in the lumbar area. And you can see there was two small surgery about metastasis resection, removing from the in the compression of the nerve roots, and then percutaneous fixation of L5 level to reduce the pain for this patient. These patients also can get the help from this pathology too, because don't afraid the oncologist patients if you want to help them to limit pain result of degenerative disorders. In conclusion, I would say that the idea of the surgery is the good selection of the patients, because it's very important. It's multidisciplinary approach personally to each patient, and you have to choose the effective strategy of their treatment with the consult of your colleagues. And I would say that the modern techniques and combination of our modern technologies with the radiologist, for example, in this case, and chemotherapy can achieve us a good results, similar with the aggressive tumor that today, I would say it's help us to avoid the aggressive surgery for this category of patients. Thank you very much.